that we've got something quite exciting for you. Some of you at Learning Session 2, providing the technology works, and you can all be grateful that I'm not managing the technology, because it clearly wouldn't work if I was. So some of you were really keen to have John Krueger, who was at Learning Session 2, come back to us, but unfortunately he can't be here in person, but he hopefully will be here by Skype. So...
Hello, everyone. I can't see you right now because I'm looking at my presentation on a view monitor from the back. So in essence, I'm kind of spying on you from behind the room, but not really. Today, and I appreciate you guys for having me here today. Like Avril said, I wish I could be there in person. Believe me, in more ways than one. I hear the weather is warming up. It's getting quite nice, but I can't. So.
Winter.
What's that?
Not the Canterbury winter.
Yeah. I trust the room's a little warmer this time around.
Yes. And it's sunny outside, and it's warm.
That's right. So, okay. Well, listening to, I only caught a few of the stories, but I'll be really looking for that poster presentation at the IHI forum. And I'll try to send you a picture of it from when I'm going around looking at all the posters that I do every year. Okay, so today, I know I don't have a lot of time, so I wanted to jump right in. We're going to talk a little bit about bundle metrics and how you optimize safety with care bundles and why that might be important to your project here. So if you see me looking off, that's because I'm looking at another screen in between. But anyhow, I'll try to look back every once in a while. So the problem that we have is there's limits on human cognition for attention, processing, and memory. We have inability as humans to do the right thing. We can only keep about 4 or 5 active processes going at any one point in time. And so that's why when I teach reliability sciences, that's one of the first things that we try to work with, not just people in medicine, but working on cars and car design and factory design and things like that and process design. We try to not overwhelm humans with a lot of different things, but sometimes you need humans to do a lot of different things almost simultaneously. And in medicine, a lot of our processes are still human driven. So that's one of the things we'll talk about with bundles. But another problem that we have is that there's usually not one thing that works all the time. And as I was listening to your stories, I was smiling because you always find out that there's, through improvement work, we always find things that we didn't think about, or how it sometimes takes 2 or 3 or 4 different things. I sent a video, I think, to Prim and John from a gentleman called Grenny. And if you've ever had a chance to look at their hand washing video, it kind of illustrates that we tend to overwhelming problems by not applying enough different modes to change those problems. The other thing is, like I said earlier, it's difficult to concentrate on a large number of non-directly related measures. So here's an example. If somebody comes to you with a whole basket worth of improvement metrics and they say, okay, we want you to work on colon cancer and blood pressure and then flu and blah, 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 blah. I mean, as humans, we're trying to put all this stuff into boxes. We're trying to sort the flu out in the immunizations box and the diabetes in the diabetes box and all that sort of stuff. And if it all gets jumbled up together, it doesn't really make sense to the way our brain tries to compartmentalize and organize things. And the last thing is that we over-concentrate in one area and then that results in a lack of attention in another area. So classic example, hospital has a campaign to improve, let's say it's immunizations, or let's say it's screening of some sort, and you're busy doing that and you neglect some other metric. And this is very, very common, is that one thing gets better because we pay attention to it in kind of a Hawthorne effect, and everything else gets worse. So next slide. So the next bundles are really a practical solution, and there is some science behind how they work, but in essence, they're more of a pragmatic and practical solution. They help us focus typically around a single issue. They help condense all the evidence that we have. Sometimes it's not even great evidence, but it's best practices and good ideas all into one area. We also get synergy. Sometimes you put a lot of great things together. The sum of the sum of the parts is it starts to the sum of the whole rather is greater than the sum of the parts. And then bundles allow us to include things which might work or add benefit, which we're a little uncertain of, and kind of test out along with other good ideas. One thing I will say about bundles is not all bundles are outcome bundles, but they do focus typically on a deliberate outcome. So you have to be clear about what it is you want. Next slide. So this is a driver diagram I use from time to time, and it's a very high level driver diagram. But over on the far right-hand side, you see materials, methods, people, management, equipment, and measurement. And that's the world we all live in. It's the messy world where doctors don't like a green stamp, but they like a red stamp. And we have to understand that and discover that. And we have resource issues, we have time issues, et cetera. But from that messy world, we're trying to get an outcome. And so we have to develop high-impact sub-processes that drive to high-impact processes that drive to high-impact outcomes. And I'll show an example of that here in a few slides. Next slide, please. So many of you are probably familiar with this bundle. This is a classic process bundle, and it is a care bundle, and it is driving, this is the VAP bundle or ventilator-associated pneumonia bundle, and it's really driving toward an outcome of trying to produce ventilator-associated pneumonias. And so on the left is what we want to avoid. That's our outcome. The care bundle are all the metrics, the processes essentially that drive toward that outcome. So you can kind of get a sense why driver diagrams are really important in this instance, because a lot of these solutions were found out at one level from condensation of driver diagrams over time. But you have head of the elevation, you have sedation vacations, you have peptic ulcer disease prophylaxis, DVT prophylaxis, and daily oral care. Those are actually our controls for trying to avoid our outcome that we don't actually want to have happen. Next slide. So I'll give you the example, and I love that example about the green stamp, and so, or the green stamp to the red stamp. So what are the things, you'll notice that head of the bed elevation at 30 degrees at all times, that's more of a broad process. It can be interpreted many different ways. And so a lot of these, we have to discover things that actually work within our own care areas. Whereas a red stamp may work in every single area, it might not work on every area, and that we have to find a challenge. Maybe a purple stamp works at certain hospitals or certain, who knows what it might be that actually works. So I'll give an example. So like if head of the bed elevation at greater than 30 degrees at all times is the process that is one of the processes that drives to reduce ventilator-associated pneumonias, well then a 30-degree lockout on that head of the bed might be a solution at one place that actually helps us get that improvement. And in engineering terms, we call that a forcing function, right? I mean, it locks out the bed. You have to manually override the bed to get it to drop below that. Another one might be an alarm or a bell or a combination of alarm and a light on the bed, that if the head of the bed goes below 30, it goes off. That might work at some areas. Again, that's an example of an audio and visual cue, which we see in a lot of manufacturing environments. We also see it in automobiles a lot, so in aircraft. So those are things that are used by other industries as well. Next slide. So what are the fundamentals that you have to design an optimal bundle? So again, the very first thing, it's got to be non-ambiguous in its focus. You got to really know what the outcome is that you're trying to go after with a bundle. You also have to be outcome oriented again, and that just kind of the orientation is always toward an outcome within a bundle. Distillation of knowledge, measure stratification. The measures need to be lined out in such a way that each measure can stand on its own. Each measure by itself ought to be able to stand on its own. And the measures need to be balanced. If you put too many metrics, for example, if your goal is to reduce opioid harm, but all your process metrics go to opioid-induced constipation, you might actually not hit that overall goal of opioid-induced harms if you have a lot of different harms included in that. And the last one is actually due to mathematics. In reliability and serial reliability, it's not a additive process, it's actually a multiplicative process. So, for example, if you have a process where each step gets 95% reliability, that is, you get it 95 times out of 100, in reality, you only get about 76% total process reliability if you have 5 different process metrics, 5 different steps, if you will, in that process. So here's a caveat about bundles and where they don't work well. So they don't work well if the processes are not well defined or understood, the knowledge about what to do is poor, the problem is not clearly defined, and the elements in the bundle are not really shown to correlate with higher levels of composite performance. We've seen examples of bundles in the past that really drive staff crazy because they kind of get thrown out there. So it's a good idea to kind of test out your bundle under a bunch of different environmental conditions, just like we did with the red ball game. So I'm going to try to bring in as many of the things that we had in learning session 2, so you can kind of see the logic behind why we did some of those things. I'd like to tell you a little bit about one of my first experiences with bundles on a large-scale health improvement project. So this is a bundle project called IPC that we did within the Indian Health Service. So our Indian Health Service is a health service. It's a treaty-derived right for our Native American populations. I'm sorry, it's on the next slide or next 2 slides. It's a treaty-derived right for our Native American populations, and it's about 3 million people in the United States, spread out all over the continental United States, Alaska and Hawaii, and some of the territories. So very broadly distributed. And what they had was they had over 200 process metrics and different outcome metrics they were trying to measure simultaneously. And in fact, what was happening was no one was doing anything very well. They were all chasing this metric and that metric. And there was no theme, or there was no harmony, and there was no synergy with the metrics. So they decided to go after some of the most common problems and actually try to improve the care of our Native American citizens with these. And so I became a part of this with IHI and the largest Native American tribe in the United States, Cherokee Nation. And so you'll notice that there's a health risk assessment bundle that's 6 measures. Those are all process metrics. There's a cancer screening bundle, which is 3 measures, which are in some sense process metrics, although one could argue this is really an outcomes bundle. There's an outcome bundle which had 3 measures, and those were what our processes were largely driving toward. And then there was a diabetes comprehensive care bundle, which was 6 process metrics. There were 6 things we thought you needed to do at least once a year to have good comprehensive care. And then you'll notice a whole lot of things like staff satisfaction and average office visit cycle time. Those were actually our balancing measures. We were looking at things like, well, okay, well, if we do this, but it makes our staff, it ruins our staff experience, if it ruins our staff morale, are we going to have a sustainable workforce that would be willing to deliver this thing? And so we measured that as a balancing metric. We also looked at cycle visit time. If we did all these, would our visits go up? And in fact, what we saw is our time of visit in the clinic went down, our quality went up. And then patient experience questions, of course, and empanelment and that sort of thing. We also looked at some other loose metrics as well, which I won't go into detail with here, but we even studied what was the impact on revenue, which I realize is not really an issue within your health system, but it's one of the ways our health system is sustained here. And here's our results. So very simple line chart or run chart, if you will. And what you see is you actually see a shift that occurs in about January of 2008. In essence, this metric now runs up in the mid-90s, and so that's actually pretty amazing because it means that this is actually an all or nothing metric still, which means that you have to do all the elements or you get no credit, and I'll talk about that in a moment. So what might a bundled metric example look like? So One of the things that you can do is you can say, well, a harm is a harm, and you can actually start looking at all of your harms as a composite rather than as a single element of harm like respiratory depression or constipation or nausea and vomiting due to opioids. And you can actually look at those. What if you were to put all those together and then take the sum of all of those, divide the numerators by the denominators, essentially for all of them? Another one is this would be example of a process bundle, a care bundle. So you might have, and these are just examples, and I want to emphasize, this is your project, and I don't want to interject my views in here. But so these are just examples, not even suggestions. But laxative co-prescribing, nausea and vomiting risk assessment, comprehensive patient and family education, and appropriate sedation, ventilation monitoring, as a few. What about balancing measures? So now I know one of the outcomes you're studying is uncontrolled pain, but you may consider that actually to be a balancing metric because we're looking for the harms. Actually, part of the focus of the project was actually harms caused by opioids. It doesn't have to be. You could still include it in outcomes bundle. It's completely up to you. I'm just suggesting you might also look at it as a very good balancing metric to hold in play, and that would assure that patients' pain wasn't rejected while we were chasing some of these other things that might come about by way of us not prescribing as many opioids, which unfortunately might drive up uncontrolled pain, which is not what we want. So when you think of balancing metrics, it is the unintended consequences of our improvements. And so we often find these out way too late, and so I think it's the most powerful thing that we actually build in to our bundles is actually having appreciation for the balancing metrics for all those improvements and bundles. So I want to emphasize this. There's two ways to design bundles, and those two ways are essentially a way that we call all or nothing. So in all or nothing, you actually have to get all the elements. So if you have 5 elements in a process bundle, just like you saw in our diabetic process bundle on a previous slide, if you got all 5, but there were 6 elements and you missed the 6, you don't get any credit for that. And while that's very rigorous, unfortunately, I've observed in groups that can sometimes cause a little bit of demoralization and some gaming too. We observed 2 phenomena to go on, and one was that teams would give up sometimes because it was very hard to achieve that bundle. And the second thing is that they tended to work on the people that had already had 4 of the 6 done and get the last 2 because they were easier to work on. So when Deming talked about appreciation of the system, remember that one of the things he was keen to talk about, and in one of his points that he made was that psychology was one of the parts of profound knowledge that you got to keep in place. So thinking about how humans are going to react to a bundle and how they're going to game it, that's how we're wired as humans to do those things. So we actually have to think about those things as we're designing them. And the second thing is composite core metric compliance. And this is actually just really essentially taking the percent you got right of each element, and then totaling those all up in kind of a numerator over denominator fashion, and giving credit for all the parts that you got of the various elements in a particular bundle. So there's a great paper on this by Jim Benion, who's a colleague of mine at Northeastern. If you want to read it, the link is here, but he really goes into kind of the pros and cons between each one. So I'm going to give you a couple other thoughts about bundles here as you go through Learning Session 3. And these are my thoughts, and then I'm going to also present 2 sides to this because IHI has some authors, and I just want to let you know that there is legitimate differences of opinion about this, about the way to do bundles. But there's no right, no wrong, but you just got to figure out which ones that you want to apply in your project. So again, I think bundles need to be based on the best evidence available. If there's no evidence available, it's the most robust evidence that you have, which may just be improvement projects going on within your organizations. Some of the things that are being done have probably not really been tried, and there's not a lot of literature on it. The other thing is that all the elements should typically be aligned to a single overall focus. So it's a broad focus, and I think in your case you have it. It's opioid safety, but you want to be careful of like getting off on tangents, and I think you're well past that place at this time. Bundles aren't a checklist, and I hear this all the time. How is it different from a checklist? A checklist, if you've ever read like the checklist manifesto by Atul Gawande and a whole host of other things, IHI Whitepapers on checklists, notice they're usually applying to typically to single people, single patients, and bundles tend to apply more to populations. The second difference between a checklist in a bundle is that a checklist tends to have temporality associated with you. All the elements performed in a discrete period of time, like an airline checklist performed prior to takeoff or prior to surgery or those sort of things. Most bundle elements don't necessarily have temporality associated with them. Another element is that ideally process bundles should be 5 elements or less. And again, you'll notice we use 6. We got away with it, but we paid the price for it in reliability at the back end. If we'd had 5, we probably would have had better reliability overall, and maybe got up to about 99% reliability. Weighing the benefits of all or nothing approach with the considerations for overall performance and the risk of unintended consequences. Again, I just emphasize to take a look at the Bennion paper. It's a little bit on the scientific side, but I think most folks will understand the gist of the paper and what he's trying to get at. They should be related to one another, all the elements, but they should also be able to stand independently. So each process ought to be able to have its own validity and be able to be measured individually as well. And then you have to monitor for unintended consequences. And again, that's the real importance of having good balancing metrics. So this comes from the Roger Resar, Fran Griffin, Carol Harridan, and Tom Nolan IHI White paper that they published in 2012. Carol worked extensively in the Scottish Patient Safety Program. She's actually one of the people that developed the BAP bundle, so she's extremely knowledgeable in this area. But I just wanted to point out that I differ a little bit for some of these projects, just for the reasons I talked about earlier. The bundle has 3 to 5 interventions with strong clinician agreement. Again, I do agree with that. Each bundle element is relatively independent. That I agree with. Everything until you get down to compliance with bundles is measured using an all or nothing measurement with a goal of 95% or greater compliance. And I think that is ultimately the goal, but when you start off with bundles, I think it's better sometimes to just see how you're doing on each bundle, each element of the bundle. It allows you to troubleshoot a little bit easier, and it doesn't discourage early participants in the project. So that's my short presentation to you, and I just want to say congratulations on all your great work thus far, and I hope you're having fun, and stay in touch. I'll be on the line to take questions after this presentation.